everybody for hanging in there. I appreciate it. I'm going to present some of the work we've been doing in this area. And as probably most of you know, the Allied Coalition, as it has been known, it actually was comprised of 39 countries of just about every continent. So even though this work has been done on US veterans, the implications are probably important in the future for veterans all over the world. It does take a village to do research, and really the leadership goes to Lisa Convoy, who's the research director at the New England School of Acupuncture. We have a team of acupuncturists, and there's also people doing biomarkers, psychosocial studies, and some complexity analysis of this work. So the Gulf War took place between 1990 and 1991 as a response of Iraq's invasion of Kuwait. And what happened is when the troops started coming back, they presented with a variety of very strange symptoms. And at the beginning, they were dismissed as being probably psychosocial in nature due to stress, but eventually people got together and started thinking about, well, what was this illness really? And Gulf War illness is now considered to be a complex medical illness that affects veterans of the Gulf War. And it has this four cluster of symptoms that we've been seeing over and over again, and there's really no standard of care for its treatment. The etiology of Gulf War illness is controversial. There's a lot of documented multiple exposures of people that were there, but they are incomplete at best. But there's several studies that point to exposure to an anti-nerve agent, which is actually an acetylcholinesterase inhibitor. I'm going to call it PB, or peanut butter, but it's actually PB for short. And the exposures were multiple, but recent research indicates that exposure not only to PB, but also to mustard gas and sarin and several other things, in genetically susceptible individuals unleashes oxidative stress that's probably what underlies many of the symptoms. The Center for Disease Controls in the United States clusters the symptoms of Gulf War illness into three. One primarily looking at fatigability that persists after 24 hours, mood and cognition, and pain, which they call musculoskeletal, even if the pain appears to be more of central origin. So, do veteran populations use CAM? Well, we've seen that they actually do. And the numbers vary depending on what population you're actually serving, but also what CAM modality you're talking about. But when you survey veteran populations or people in the armed forces as to whether they would use CAM, they say they would really use CAM if it was offered within the system, and whether they are active duty personnel or whether they are veterans of a war. So we saw with Remy's talk that really, at least in the United States, it is pretty widespread use of CAM. So, you know, given that some of the preliminary research in acupuncture indicates that maybe there's some way to effectively manage conditions that share a similar cluster of symptoms, we wanted to find out, well, is acupuncture effective in the management of Gulf War illness? And to inform our research, we wanted to begin first by looking at a way of informing the dose and the treatment based on TCM, then design a high-quality randomized control trial, look at some evidence of clinical effect, and then we moved forward to doing secondary data analysis. We wanted to look at statistically relevant information on biomarkers, as well as clinically relevant information on traditional Chinese medicine. And then we moved to a third grant, looking at program evaluation. And that's to answer, well, is this really a viable treatment option for veterans? So as an overview, I'm going to present really quite briefly these three areas: the randomized controlled trial, the secondary data analysis, and the program evaluation. And the randomized controlled trial, the study has been published. And this is what we call our parent project, which was funded by the Department of Defense in the United States. And we set to evaluate whether the effects of individualized acupuncture treatments, whereas they were offered in extant practitioners' offices. So in this way, it was a completely pragmatic trial. We farmed the patients to practitioners on the community. And we wanted then to explore traditional Chinese medicine disease mechanisms to develop a heuristic and best practices. So our parent project is an unblinded phase 2 randomized controlled trial. We randomized 104 people into a waitlist control where they waited for 2 months, and then they received weekly treatment for 4 months versus an active group that received bi-weekly treatment for 6 months. And we included people that had served in what is called the Gulf Theater of Operations, a pretty large geographic area. They are all US veterans. They have to have at least 2 symptoms from the 3 CDC clusters that lasted more than 6 months. They were mild, moderate to severe, but at least they have to have 1 symptom that was severe in each cluster. They couldn't have other illnesses that accounted for the symptoms, and they couldn't present with a psychiatric illness in the last 2 years. So as you can imagine, recruitment was rather challenging. Luckily, however, we were able to access what's called the manpower database, which is a database of all people that serve in the armed forces in the United States. We sent an opt-out letter, and we conducted advertisement as well. They could opt out, but then they underwent, if they decided to continue, through 2 different screenings to make sure that they met eligibility, and then those that were eligible were consented, and we began the baseline measurements. We had really a pretty low dropout rate of only 17 people. And just to point to you the baseline characteristics in our main outcome measures, the difference between the subjects randomized to bi-weekly or weekly treatment were not statistically significant. So we conducted a variety of measures. You can see here we did some TCM measures looking at pattern differentiation, alliance, and expectation. Then we looked at mood and cognition, anxiety, and social support. And we did some biomarkers looking at select markers of inflammation, immune function, and stress response. And finally, we looked at function and symptoms, our primary outcome being the SF-36, the physical component of it, and the McGill Pain Scale. These are standard scales. Everything that we use were standard cares in the field because there really are not standard measures for this patient population. And then we took the traditional Chinese medicine intake, that is the New England School of Acupuncture form, which has a health history questionnaire. We applied that at baseline, and then we did monthly progress reports until the completion of the study at 6 months. And then, before starting, we set out to characterize the Gulf War illness in traditional Chinese medicine, looking at the literature, talking to some experts, and some trials of patients that had had exposure to neurotoxicants. And we designed a treatment that would be individualized because the population is highly heterogeneous in their presentation. We used some information from TCM neurology. We also looked at Weijing flaccidity syndrome, which is documented in TCM studies of organophosphate poisoning. We looked at B syndrome, given that pain is a big component of this syndrome. And then we looked at imbalance of yin and yang. You could say that. That's an autonomic nervous system dysregulation because many of these patients present with cholinergic dysautonomia. So our treatments were based on 8 principles. The strategy was individualized. The practitioners were told to address the most distressing symptoms, additional symptoms, and the patient's root condition. The treatment was needling with the chi sensation. All allied techniques of acupuncture were used and all forms of stimulation, but we didn't accept any herbs or supplements. And the providers were senior practitioners in their private offices. They were trained in Gulf War illness as a general way, and we talked about a few of the features, but they were allowed to do however they would treat these patients in their own practices. If we look at the stricter criteria, and we organize it that way, looking retrospectively, we can see more details of the acupuncture needling itself. So this is really sort of looking at raw scores, which is the easiest way to look at it if you're not a biostatistician, which I am not. And you can see that the greatest improvement was at the end of 6 months. At the very beginning, people actually got a little bit worse, but this is not statistically significant. But this indicates that dose of treatment may actually matter in this population. Patients receiving weekly treatment didn't do that great. And then if we look at the McGill pain score, you see a pretty nice dramatic change in those patients receiving biweekly treatment. When you aggregate the scores of both groups and you look at the change between month 2 and month 4, that was pretty significant difference, and that's where we found the greatest differences was at that point in time, which is not uncommon in acupuncture studies. It's about 4 months, 2 to 4 months, 4 to 8 weeks where you see the greatest change. The data was actually published using regression analysis, but I just want to point something out to you in terms of the results. This is a way of looking, if you compare biweekly treatments with weekly treatments, at the end of what you really consider to be your clinically significant time, that is 6 months, there was a pretty neat difference in the SF36 and an improvement of 9.4 points right here. So there's an increase in their function score. It was comparable to the McGill, where the biweekly group at the end of 6 months had approximately a drop of 3.6 points. Both are clinically and statistically significant, which is, pretty much what I said in the raw score data. It's a little easier to look at, but this is really looking at the end of where the dose response seemed to be the most significant. If we look at whether they used, the patients were confident with acupuncture and they would use it and recommend it to family, about 96% of patients said that they would. This is in a scale from 0 to 5. Most of them, the ones included in the 96%, endorsed either 3, 4, or 5 on that scale. And same here, when you're thinking about whether acupuncture was pleasant or unpleasant and whether the relationship with the acupuncturist was good or not good. Okay, so looking at the secondary data analysis, I'm just going to give you 2 very brief examples, one coming from TCM, one coming from the biomarkers. And we did a matrix analysis of TCM differential diagnosis. And this is not work that I personally find very useful, even though I fully participated in that. We did descriptive statistics, trying to categorize differential diagnosis from baseline to 6 months, and whether there was a consistency of patterns or a change in differential diagnosis. And I'll explain in a minute why it's a little bit disappointing. The data was double-coded by 2 licensed acupuncturists with quite a bit of experience, does not include me, and the reliability between them was actually very good. So as you can see, we looked at differential diagnosis in 3 domains at baseline. We looked at occurrence of differential diagnosis again at baseline. Did people have excess or deficiency alone, or excess and deficiency, or excess, deficiency, and channel problems? So we were kind of trying to categorize it. And then we compare it at 6 months. And only one category had more frequency at the end of the 6 months. Most of them dropped off. But, you know, in my opinion, this really brings more questions than answers. It points out to the difficulty of categorizing and doing reliability studies across subjects and practitioners in TCM when you're not using a form that has been validated. So you're looking retrospectively and coding the data, which is a mess. So we are exploring some of these common symptoms. It may give us some good information, and we want to develop a heuristic about the etiology and the dynamics. Maybe we will write a treatment plan, maybe we'll be able to make best practice recommendations, but we didn't get as much information as we wanted from that. So really, to conclude this biomarker analysis, remember we were looking at this translational research strategy. How do you inform trials from practice? And then how do you inform practice from trials? And this is a really sweet, beautiful study that the other teams conducted, looking at novel central nervous system biomarkers in veterans with Gulf War illness. And they compare in this little pilot samples from our study with non-veteran symptomatic people with chronic lower back pain. And they look at serum antibodies, and they screen them for essential neuronal and glial proteins that have been found to be significant in patients with brain injury. They also look at autoantibodies that had been identified as being potentially objective biomarkers for this population. And then they did a Western blot analysis of 9 proteins. And the really interesting thing is that subjects with Gulf War illness had significantly associated a 2 to 9-fold increase in serum autoantibodies against 8 neuronal and glial specific proteins, but not associated with a marker that has more to do with acute damage rather than chronic damage. And the implications really are that these autoantibodies that are found to be elevated in Gulf War illness patients play a critical role in the structure and function of the neurons. Many have been found to be explicit markers for neurodegenerative disorders, and some of these proteins have been shown to be affected in other clinical groups and in animal models that have had similar organophosphate and carbonate exposures. I found this to be really quite interesting because when you're thinking about acupuncture, if you really think of the body as a garden, and if you really think of acupuncture as regulating the irrigation system of this garden, asking what may be the mechanism by which acupuncture may have an effect in this population is a fascinating question, which we may be able to answer when they look at the biomarkers pre and post acupuncture treatment. We may begin to elucidate some of this, and it's some of the questions that my colleagues have asked before. We are conducting several other studies that are currently in process, and we're trying to figure out if we can design a successful treatment. And we started by doing a focus group with our practitioners, saying, okay, how did you go about treating these patients? Again, retrospectively wasn't particularly helpful, but we're just finalizing conducting these diagnostic interviews about how they reason about their diagnosis, and it's currently being analyzed, looking at a complex modeling of the traditional Chinese medicine disease diagnosis and comparing that to some of the biomedical diagnostic reasoning. And this is being done by asking very specific and in-depth questions of the practitioners one-to-one. We want to try to see, is there any generalizable trends, any effective strategies, any clinical pearls? Is it different by practitioner experience? And I just want to conclude that to point out that what is called as the theater of operations in the Gulf War includes thousands of civilians. So the effects of this, whatever is it that has caused Gulf War illness in veterans, is probably affecting large populations for generations to come. And I also want to point out that there are many people in our practices. I really specialize in chronic fatigue, fibromyalgia, and dysautonomia in my acupuncture practice. And these patients share many of these characteristics. And just leave you with a quote by one patient: "We may not look sick, but turn our bodies inside out," and they would tell different stories. These people have been marginalized for decades. I thank everybody who made this work possible, and I thank you for hanging in there this late in the day. Thanks so much.